Hello, welcome and thank you for joining us today as we continue our IB Users Group webinar series. My name is Linda Herman. I'm the Client Relations Manager for Imaging Biometrics. Today's webinar is titled Advanced Imaging Techniques for Biopsy Targeting and LITT in Recurrent Brain Tumors. It is presented by Dr. Max Krucoff, a neurosurgeon at the Medical College of Wisconsin. We've muted microphones and ask that you use the Q&A feature to ask questions at the end of the presentation. Today's webinar will be recorded and made available for future viewing. And now I'll turn it over to Dr. Krucoff.
Thanks, Linda. Thanks for inviting me to talk today. Today I'm going to talk about how I use advanced imaging techniques to improve results for stereotactic biopsies and laser ablation in recurrent brain tumors. I have no financial disclosures. So a brief outline of today's talk. I'll start by outlining modern treatment for recurrent brain tumors and some of the newer options that are quickly becoming standard of care, specifically biopsy and laser interstitial thermal therapy. I'll do a very brief evidence review, sort of what the goals of the treatment are and why we're doing it. And then I'm going to segue into the advanced imaging that started to integrate into this workflow, specifically delta T1 and fractional tumor burden maps. I'll show a few case applications and then I'll have time for questions. So very briefly, intraaxial brain tumors are tumors that are in the brain themselves. They're generally divided into two categories: primary brain tumors or gliomas, and metastases, or tumors that can from cancer somewhere else in the body, like the lung, the breast, the skin, and then metastasize to the brain. Standard of care for small metastases is stereotactic radiosurgery. And if they're large or symptomatic, surgery plus stereotactic radiosurgery. Nowadays, it's pretty much a consensus guideline. It's not very controversial. We really know how to treat these pretty well with pretty good results. For primary brain tumors like glioblastomas, if it's surgically resectable, it gets resected and then followed with radiation and chemotherapy. But eventually, a lot of these things recur. And you have the subgroup of recurrent brain tumors and non-resectable brain tumors. And for these people, there's really no clear standard of care. I've had patients describe this to me as the choose your own adventure part of their cancer journey. So I'll show you an example of a case like this. So this is a 78-year-old woman with non-small cell lung cancer who presented with a new left frontal metastasis. It was small, it's about 2 centimeters. So clearly, the right thing to do is stereotactic radiosurgery. There's really no role for surgery at this time. She had Gamma knife, and 2 months after, initially had a very nice response. But then at 4 months, started to have recurrence. So can you guys see my mouse, my cursor? Well, I'm going to assume you can. If you can't, somebody let me know. So here you can see the metastasis come back, and this is a FLAIR image showing a fair bit of edema or swelling around it. So now the question is, what do you do? So now you're beyond sort of the standard care approach. So at this time, the main question is this recurrent tumor, or is this radiation necrosis, or is this a combination of the two? So a lot of places, including Medical College, use MRCBV, or relative cerebral blood volume scans, to try to help differentiate. They can be helpful, but they can also be equivocal. So in these scans, higher blood flow is red, and low blood flow to no blood flow is blue, and green here is kind of intermediate. So we're suspicious this is a recurrence, but we don't know for sure. So here's the question of next steps. And I think if you poll 10 places, you'll probably get 11 answers. So what do you do next? You just empirically re-irradiate. Do you surgically resect it? You take a biopsy to see if it's radionecrosis or not. You re-image it in a month. You start running Avastin, and then what? So this is really where laser interstitial thermal therapy has found a great home. LITT is a minimally invasive alternative to open surgical resection. It uses heat to ablate tissue rather than surgical techniques to resect it. It's a surgical technique. It is not a radiation technique, so it's a replacement for surgery, not radiation. The goal of the procedure is cytoreduction, basically to reduce the number of cancer cells as quickly as possible. And extensive ablation, or how big a treatment zone you get, is thought to be about equivalent to extensive resection. So if you can ablate 100% of the tissue, it's about the same oncologically as resecting 100% of the tissue. This is sort of our current working theory, but has not been rigorously proven. And it uses the same tract as a biopsy. So really the risk in undergoing additional laser placement is pretty similar to undergoing biopsy. So what's the evidence for LITT? Basically, in recurrent brain metastases, LITT plus radiosurgery has been shown to increase the time for mobile progression. So this is data showing freedom from mobile progression. LITT plus SRS in this study was about 30 months, whereas SRS alone is about 4 months. What about for radionecrosis? So if you take a biopsy and with radionecrosis, do you still do it? Well, it turns out there's a benefit to getting people off of steroids much more quickly in radionecrosis. And that can be huge, especially nowadays in the era of immunotherapies, where steroids really impede the primary cancer treatment. In this study, the average time to off steroids after LITT was 37 days, whereas medical management alone was 245 days. So quite a difference. There's basically consensus statements from the AANS and the CNS, or two large governing bodies, acknowledging these indications, the National Cancer Network as well. So this has really become a standard treatment in these cases. So the next steps for this case, we did biopsy and LITT. I can sort of show you an example of what this looks like. But basically, the laser probe is placed down into the lesion through a tiny, about ½ centimeter incision, about a 1/4 inch burr hole through the skull. And then the patient's brought into the MRI suite, and you can heat up the laser and you can watch it expand the heat zone, the kill zone, the ablation zone under real-time MR thermography. And you end up, so this is the pre-treated lesion, and then immediately post-treatment, you can get a 2-on post contrast, and you can see the margin of the actual treatment. So in this case, here we have pre-op. You have T1 pre here, T1 post here, and the flare here. And then here's our 24 hours. So because LITT ablates tissue, it leaves coagulant necrosis behind, which is T1 intrinsically bright. And it can make the evaluation of your immediate post-operative scan much more difficult. So just by looking at this, it looks like there's probably not any residual enhancement at 24 hours, but it's difficult to tell. Once you get out to a month, it's a little bit easier, but in the immediate post-operative assessment, telling your extent of ablation can be difficult with standard units. And so that's where delta T1 maps. I've really found them incredibly useful. Delta T1 maps at their simplest is basically a subtraction map between T1 post and T1 pre, but it's a little bit more complicated than that. There's a standardization technique, and it's really an evaluation of the extent of persistent enhancing tissue left behind. But basically, you start with a registered T1 pre, a registered T1 post contrast, and then it gets run through a standardization algorithm. And you come up with this blue to red scale, where the darker red is the more enhancing the tumor is. This has been validated in postoperative primary glioblastoma resections to evaluate extent of resection of the enhancing portion of the tumor, which is known to correlate with survival. This was published last year, where residual delta T1 volumes stratified survival as you'd expect. So this is a case I did recently, laser ablation of a recurrent glioblastoma. So here's the pre-ablation scan, T1 pre, T1 post contrast, and delta T1. You can see the contrast enhancing portion of this lighting up. I did the ablation, so now all of a sudden you have all this intrinsic T1 signal and this T1 post contrast. And it's difficult to visually assess this. And this is where the delta T1s really come in handy. You can look at the delta T1 pre, the delta T1 post. This is choroid plexus, which is normal vasculature. And you can see we really got a nice margin of ablation. And this is really nice to show to patients too, because trying to explain this to patients is really difficult, but they can see a big bright red spot that's not there after the treatment, quite intuitive. Here's another example of a case of a recurrent cerebellar met, which we treated with laser ablation. And same thing, so you can see this intrinsic T1 pre, which now shows up, a little difficult to tell, but you can see just this sort of rim of reactive T1 post contrast, and you can see the difference between the two just very intuitively with these delta T1 maps. And because we did this with LITT, she had just a few staples as opposed to a big posterior fossa craniotomy. Deep-seated lesions are also well treated with LITT. This is one that initially got SRS and recurred. Again, just the demonstration between the pre-treatment and the post-treatment delta T1 is night and day. So for recurrent glioblastomas, it's thought to be about the same. This is basically an ongoing registry of 12-month outcomes for quality of life after brain tumor ablation in primary brain tumors. Here's an example of a case of mine. This was an insular glioblastoma that I open resected initially, and I think about 18 months later, it started to recur. She was asymptomatic, but there was clearly this mass here, difficult to get to, didn't want to undergo another open resection, so we treated with laser ablation. And you can see the delta T1 shows the extent of that ablation quite clearly. So in some neurological indications for LITT, basically recurrent NETs and radiation necrosis, at the time you think you might need a biopsy. Recurrent GBMs, if they're surgically inaccessible, if they're not good surgical candidates otherwise. And then surgically inaccessible primary tumors also LITT can be a nice tool for example, in the basic endo. So one thing I haven't touched on is the biopsy portion of LITT. Biopsies are a little tricky in this population because lesions are notoriously heterogeneous. So that's where these fractional tumor burden maps are found to be incredibly useful. Basically, the way it works is you outline the contrast enhancing portion of the brain with the delta T1, and then you incorporate and analyze the standardized RCBV. And what they've done is through a series of spatially registered biopsy samples, generated an algorithm to predict the probability that the biopsy will be positive for tumor depending on its location. So this really shows you a visualization of how heterogeneous these recurrent lesions can be, because a lot of them contain tumor necrosis, a lot of them contain radiation necrosis. And if you biopsy those areas, you may get a non-diagnostic or a wrongly diagnostic sample. So that's been a push for a long time in the field to do open surgeries, but the difference between doing an open surgery to get more tissue for the patient versus stereotactic biopsy is a huge difference in terms of the risk profile and the morbidity. So if you can do a stereotactic surgery, but do it more accurately, then you obviate the need for opening anything up. So basically, the way they built this algorithm is spatially registered biopsy samples, and they were able to stratify them. So this is validated in glioblastoma. It's not yet validated in metastases, but I think that's in the works. And you get these confidence intervals for, if the standardized RCBV has these values, chances are it's going to be high probability to be the tumor. If it has lower values, these are sort of the cutoffs. So that can generate this heterogeneous map that can help me figure out where I should biopsy. This is an example of a LITT case that I did, where you can see this contrast enhancing lesion, and this is the LITT trajectory, and the pink box is the biopsy window. And here you can see how heterogeneous this tumor is. And this helps me target the area of the tumor along this trajectory that is most likely to contain viable tumor tissue. This was recently presented at ASNR and it won an award. You can see the accuracy, sensitivity, specificity, positive predictive value, and negative predictive value so far is pretty darn good. Here's a case of recurrent multifocal treated glioblastoma, and you've got sort of a few options of where you might go. Here you can see it in 3D. Here you can see where the biopsy sample was taken in an area that was red on the fractional tumor burden map. It was pathologically recurrence from a single stereotactic biopsy. This was an interesting case. I thought this was a patient with multiple metastatic melanoma, multiple lesions, who were symptomatic from 2 of them. And so we did laser ablation of 2 of them after he had whole brain radiosurgery and started from that. And the sort of inferior frontal one was completely blue, and the sort of middle frontal one had a patch of red. So because I needed 2 trajectories to treat both of these lesions with LITT, I sampled both sites. So we had a direct comparison, same patient, same tumor, same treatment, 1 blue, 1 red. Here you can see the spatially registered sample. So here's the middle frontal one. Here's the inferior frontal one. And sure enough, the middle frontal one came back positive for metastatic melanoma, and the blue one, inferior frontal one, was negative, and then positive for necrosis. So there are a few limitations to these techniques that it's important to acknowledge. Delta T1 and FTP maps both will incorporate blood vessels and include blood vessels. They measure, at least included in what they measure, is vascularity. So for surgeons starting to target these areas, you have to be cognizant of that and make sure that I wouldn't just blindly target a red area. You got to make sure you're not going to biopsy a blood vessel because that can cause damage. FTP map accuracy has not yet been validated in recurrent metastases, so that's still waiting to be finalized. This assesses contrast enhancing areas only, so this is not applicable for non-contrast enhancing regions. And then currently, I use it to make decisions within what would otherwise be my standard of care. So like if I have two what I would consider equivocal biopsy trajectories, and one of them goes to red and the other one goes to blue, I'll pick the red one. But I won't go sort of beyond standard. I won't do like something dangerous or anything to go after a red region if I think there are blood vessels or it compromises the trajectory. So it basically helps me fine tune where I would be considered. So this is a huge collaboration, basically mainly the Schmeidel lab at MCW and the Imaging Biometrics team, and funded by several NIH grants to the Schmeidel lab. I'm happy to answer any questions.
Thank you, Dr. Krucoff. We'll wait and see if we have any questions for you.
All right, we do have one question that showed up in the chat. Dr. Krucoff, maybe you can mention our imaging approach to suppress blood vessel signal for future maps.
Yeah, so questions about one of the limitations I mentioned, that Delta T1 and FTP maps both incorporate blood vessels. We are experimenting with some MR sequences that naturally suppress blood flow. So that's a limitation that's currently being worked on.
Dr. Krucoff, how hard or easy is it to incorporate these maps into your navigation system?
Currently very easy. Basically, we've got to a workflow now where it shows up as an image on PACS. So I use BrainLab, and so I just BrainLab queries our PACS system, and you can just select whatever you want and bring it into navigation. And this image is an image that's a screenshot straight from BrainLab.
I don't see any more questions, Dr. Krucoff. If we don't have any more questions, I just want to thank you for attending today's webinar. And please watch for invites for our January 6th webinar with Dr. Brian Koppel of the Mount Sinai Health System, titled Utilizing QSM for Deep Brain Stimulation. It looks like we do have one more question. Regarding the melanoma case, why do you think was one lesion negative while the other was positive?
Yeah, good question. Could be a lot of reasons. Could be the initial size of the met. I think the biopsies were accurate. Like I think the one site was really well treated and was radiant necrosis, and I think the other site had active tumor. Why one lesion responded to whole brain while the other one didn't? That's a great question.
Do you see that very frequently, Dr. Krucoff?
I wouldn't say very frequently, but I guess frequently enough. It's pretty rare that we have the indication to go back in on somebody with multiple brain mets like these. And as you can see, he's got sort of brain mets all over. And a lot of these were probably viral tumor. So it's pretty rare that we have a surgical indication. This one was really, his executive function and his cognition was suffering, and what's felt to be due to the left frontal lobe edema. So we tried to get those two big agents treated to help his cognitive symptoms. But in most cases, with multiple mets like these, there's not much surgical indication. That's why I think this is a new case.
Great. Okay, it looks like there's another question. How about using quantitative T1 maps instead of T1 weighted image pre and post contrast?
Quantitative T1 maps instead of T1 image. I guess I'm not familiar with quantitative T1 maps. If that person wants to unmute maybe. And
yeah, we'll see if we can unmute them.
Is it because quantitative T1 maps take a lot longer and are not routinely collected?
I'm not familiar with them, So I don't know, but really what you need is the difference between the T1 pre and the T1 post contrast.
Yeah, and all that is fully automated with our software platform, so you can get those directly into your navigational system without any manual intervention.
Yeah, I can speak now, so thank you. So I see that in your presentation, you are looking at the delta T1, which is based on pre and post contrast T1 and using some kind of calibration. And so therefore, I thought that if you can get to a more quantitative T1 map, which might allow the differences to be more quantitative as well, eliminating some of the errors in the calibration.
I probably
the delta T.
Yeah, go ahead.
I'm sorry. The delta T1 maps are fully quantitative across time and scanners and field strengths. So there's an intrinsic numerically characteristic value in with that. So it's not a relative or subjective output map. It's truly quantitative.
So are those just the difference in terms of image intensity and pre and post contrast?
Yeah, that's the details of the standardization technology. It's a calibration to a fixed and consistent scale that's done once for all time, and it's built into our software that makes the output truly quantitative.
As you know, there are many factors impacting the signal intensity, and doing that kind of calibration is challenging. So therefore, doing a more quantitative measurements might allow more reliable comparison at a different time point.
But that's the beauty of the standardization technology that's built in. It addresses all that, it accounts for all that. And again, independent of which scanner platform you're using or field strength or patient or time point, the same values do apply to the same consistent scale.
Right. Yeah. It's like I wasn't able to talk if I could just jump in. So yeah, quantitative T1, as you're mentioning, what you do is you, of course, can collect it at multiple TRs or TIs, and then you could actually compute the T1 map. And that was, that's something that's been taken off scanners years ago, so it's not readily available. And it's very time consuming, as you probably are well aware. And so the delta T1 maps really sort of preclude the need to do anything like that, because they are actually probably more consistent across scanners and field strengths, because they're not field strength dependent like measurement of T1 actually would be. So it's a really easy way to get the quantitative information without having to do all the extra fitting.
Thank you, everyone, for those comments and those questions. Do we have anything else? Dr. Krucoff, in practice, when do you feel LITT is a better choice than the standard open approach for recurrent tumors?
In small lesions, almost always. In big lesions with mass effect and a lot of edema, midline ship, I think open is better. Deep-seated lesions, they're difficult to get to. I think LITT is probably better. And then in people who are just not good surgical candidates, low resilience, people who don't want to undergo multiple craniotomies, I think LITT's probably better. But really, tumor size and mass effect and edema, I think, are the differentiating factors.
Do you see a role for delta T1 with intraoperative MRI scanners?
Yeah, great.
Okay, well, those are some great questions. This was a great discussion. Thank you again, Dr. Krucoff. Please look for our invites for our January 6th webinar, and thank you all for attending. Have a great day.